Hello everyone to today's session of bronchiectasis. We will discuss about diagnosing different types of bronchiectasis from the CT images. I'm Dr. Sakib Navi Siddiqui. I'm a consultant in respiratory medicine in James Cook University Hospital here in UK. I'm also the service lead for ILD and bronchiectasis services. So let's begin first with a couple of myths that exist with bronchiectasis. A. Traction bronchiectasis is not bronchiectasis. Today's day and age, we use the term as secondary bronchial dilatation rather than traction bronchiectasis. And bronchial dilatation is not always bronchiectasis. If you look at these couple of images here, so let's have a look at this image first. So you can see bronchial dilatation here, but if you closely see, there is associated interstitial and lung parenchymal damage here. So clearly some fibrotic changes are noted here. So what happens here is, due to the lung fibrosis, the bronchus is pulled towards the fibrotic tissue and you have dilated bronchus, which does appear like bronchiectasis, but this is not a true bronchiectasis. This is commonly found in interstitial lung disease, particularly in UIP pattern or IPF. There is a video in the channel about UIP pattern lung fibrosis where this has been discussed as well. So this is traction bronchiectasis or secondary bronchial dilatation due to associated lung fibrosis. Compared to this CT, where you can see the bronchus dilated from the very proximal to the distal end, and have a look at the associated lung tissue. There is no lung fibrosis. You can see some mucus plugging here, and you can see some infective changes / inflammatory changes here, but there is no obvious lung fibrosis surrounding the dilated bronchus. So this is a typical bronchiectasis. So keep in mind, traction bronchiectasis is not a real typical bronchiectasis. Look at the surrounding lung parenchymal tissue. Is there any evidence of fibrosis? If so, it is a traction bronchiectasis or a secondary dilated bronchus. Similar story happens in infection as well. If you have an active infection, then the bronchus due to inflammation gets dilated. You treat with antibiotics, you repeat the scan, and you find that the bronchus is resolved. There is no further dilatation of the bronchus. So again, that is simply bronchial dilatation secondary to infection. It's not a typical bronchiectasis. For a typical bronchiectasis, we can summarize there are 3 cardinal features and 3 additional features. The cardinal features are the bronchus has to be non-tapered and dilated. Usually, the bronchus is more dilated than the adjacent vessel, approximately more than 1.5 times, and often the bronchiectatic changes are also noted in the lung peripheries. Just have a look at this. So this is the main principal bronchus, which divides into the lobar bronchus and the segmental bronchus. So if you follow this bronchus, it's dilated and non-tapered from proximal here, from proximal to distal. So it's completely dilated and non-tapered from proximal to distal. This is not how it is on a normal CT. On a normal CT, generally the bronchus tends to taper along as it moves from the proximal to the distal territory. But if you have a look here, the bronchus is completely non-tapered and dilated from proximal to the distal. This is a classical features of bronchiectasis. Then you have dilated bronchus, as you can see here. Secondly, again, you can see this is very classic, non-tapering of the bronchi. So you can see the bronchus from proximal to distal. It's going there, it's going there, it's going there. There is non-tapering dilatation of the bronchus from proximal to distal. Then secondly, as mentioned, bronchial dilatation and it appears as a signet ring. So basically, each of these bronchi, if you follow this, each of the bronchus is surrounded by adjacent vessels. That's a vessel, that's a bronchi. And generally, the bronchus should be smaller in size compared to adjacent vessels. But if you have a bronchi which is more dilated than the adjacent vessel, then it appears as a signet ring, just like this top of the vessel at the top of the bronchus appears as a signet ring. And thirdly, I mentioned that often we note bronchiectatic changes at the periphery of the lung. So you can see here at the periphery of the lung, there are certain bronchiectatic changes. So these are the classic features of bronchiectasis: dilated non-tapering of the bronchi, dilated bronchi which appears as signet ring as the bronchi is just becomes larger than the adjacent vessels, and there is often bronchiectatic changes noted at the lung peripheries. Again, another slide. This is a classic one. So you can see the bronchus is dilated and more so than the adjacent vessel, and it just looks like a signet ring. We will move into additional features where you can see that because of this dilated bronchus due to ongoing infection or inflammation, the bronchus is dilated and filled with mucus and fluid. Again, typical signet rings here, and you might also hear the term called tram-track term or tram-track sign rather. So that is basically, if you follow this non-tapered dilated bronchus, it's like a parallel railway track where you have opacity here and a parallel opacity here surrounding the dilated bronchus, a very classical sign for bronchiectasis. As I was mentioning, apart from the three cardinal features, there are three additional features as well. Bronchial wall thickening, we just discussed, and often presence of nodules or tree in bud appearance and air trapping. So we can see these bronchus here, which are dilated and filled with mucus and fluid. And if you closely have a look at the peripheries, there are lots of nodules here. This is more commonly found in infection, and you can see a bit of tree in bud here as well. So these are very commonly found in infection driven bronchiectasis, where you have tree in bud nodularity. So you treat with antibiotics, and then potentially when you repeat the CT, they get resolved. If not, then we eventually have to take some lavage samples just to make sure there is no atypical bugs, TB, NTM, or any likelihood of underlying malignancy. So the additional features are bronchial dilatation, lots of mucus and fluid, tree in bud appearance, nodularity, and I was mentioning of air trapping. If you look at the axial views here, and especially if you do a CT in prone position with the expiratory films, you will find lots of air trapping here. So if you look at the lung density closely here, this is the normal lung density, and in between you have air trapping. Because eventually bronchiectasis is an obstructive airway disease, it can cause air trapping. To summarize, we have got three cardinal features of bronchiectasis, which is non-tapering of the bronchus associated with dilated bronchus more than the adjacent vessels, and often presence of peripheral bronchiectatic features in the lung parenchyma. Then we have additional features suggestive of air trapping, dilated bronchi, nodules, and tree in bud appearance. Generally, you will see these three patterns of bronchiectasis on a CT. The most common being cylindrical pattern, where you just have dilated, non-tapered bronchi from the proximal to the distal. Then there is a bit of a mixture in varicose bronchiectasis, where you actually have dilated, non-tapered bronchi, but they are a bit irregular. If you compare this to the cylindrical one, which is smooth and regular, this bit is a bit irregular here, and that is the varicose bronchiectasis. And if you see cystic pattern in clusters, then that's the cystic bronchiectasis. You can often reach into the diagnosis, or at least the differential, based on the location of bronchiectasis. If the bronchiectatic changes are located primarily in the upper lobe, it's commonly due to TB or post-TB or sarcoid or a cystic fibrosis, which eventually diffuses throughout. If you commonly notice the bronchiectatic changes solely in the middle lobe, then it's due to atypical infection, NTM, or an aspergillus. And most commonly, when you see bronchiectatic changes noted in the lower lobe, it's commonly due to aspiration or recurrent infection. You have to look into microaspiration, evidence of regurgitation, or do a bronchoscopy to check for any atypical bugs, as commonly is due to recurrent infection. Many thank you for listening to this video. I hope it's useful. You can follow me on X. The handle is just in front of you. Many thanks. See you in the next video. Bye bye.